It should be good right now. All right, hold on. I'm seeing. All right, good. It's connecting right now. All right, we're about to start. Hello, hear me?
Mm-hmm. I'm just waiting for yours to
All right,
pop up.
it's
So
good. It's up right now. All right. Hello everybody. We are here with a study with me. We're doing a 90-minute Pomodoro session. That's 30 minutes studying, and we are going to be doing 30 minutes of studying and a 5-minute break. Um, as I turn on this counter, I'm going to turn down the volume, and then we're just going to get into it. All right. Without further ado, here we go. Let's start. Okay, timer's up. Good. All right, let's guys, let's go. All right, turn down my mic.
okay. Yep.
time for our break. We will be coming back in about 5.
Am I wrong for trying to take notice? Is it wrong that I made a mark? Is it wrong that I got the motive?
second here. All right. Oh, it does look like my camera went out. I'm not sure what was up with that. Hold on 1 second. Hold on. Andy, I'm going to put it back on the study break. Fuck. Let me put it back on the study break.
Am I wrong for trying to take notice? Is it wrong that I gave a mark? Is it wrong that I got the motive? It's been so long that I can write it out. I can feel no water. Isn't that true? Feeling almost done as time must be my God. Can't take no more. I can feel no water. Isn't that true? Feeling almost done as time must be my God. Can't take no more. Take no more. Take no more. Take no more.
All right. Can you hear me? All righty. One more thing. All right. So let's get into it. So let's take this countdown timer off real quick. All right, music's off. All right. So what we'll do in this section, let me make sure your volume's up. All right. Can you say something?
Yeah, can you hear me?
Yeah, cool. I can hear you. All right. So what we'll do in this section is we're pretty much going to be going through just general musculoskeletal evaluation. We'll start off with dermatomes and myotomes, and we'll just progress through. So we'll just do it kind of like a round robin. I'll ask you one, you'll ask me one. If you don't know it, it's cool. What we'll do is, if you don't know it, let's start off with 7. So do you have the app, the Quizlet app?
Quiz,
Say it again.
my yeah, I have it on my yeah, but on my iPad.
Okay, cool. So go
Okay, yeah,
ahead
we
and
can.
open that musculoskeletal evaluation, and this is actually the this is partly from the readings from Final Frontier, pretty much the dermatomes, myotomes that they, it's from their standpoint. So I'm gonna go with those. So you can open those up, and what I want you to do real quick is we'll go through the first 7, we'll highlight 7, and we'll just kind of go from there. So what you're gonna do is you're going to star the first 7. So the capsular patterns, that's actually what it starts off with.
Yeah.
So star those 1, 2, 3, 4. This is usually how I do it. 5, 6, 7, and a little bit of orthokinematics. Yeah, 7's good. So you should stop at concave moving on convex.
Gotcha.
You got that?
Mm-hmm.
All right, now go ahead and click the study section. And people, if some people are watching too, if they need to just go over general, this is kind of basic stuff, but this is a format of how we'll be doing things. So go to study 7 and then click flashcard mode after you've highlighted the 7. So it should say study
Okay.
7. Huh?
It'll say 7 out of 81.
Yep, 7 out of 81, and then click flashcard.
Yeah, I'm on it.
All right. So once you click flashcard, you just got to go into your. Oh, never mind. This is not learn mode. This is flashcard. Okay, cool. All right. So you can start off with me because I've reviewed some of this stuff. So, and if you don't know it, I can
Okay.
answer it for you and then we'll just go back. So if you don't get it right, go ahead and swipe it. I'll just swipe with you because it'll just be reviewed to me. You can swipe it to the left. If you get it right, you can swipe it to the right. If you
Okay.
have an
Or
idea,
how, if you've already done these, then
I've
you
done
can
them,
just
but I
let me know.
haven't studied these in a while.
Okay.
Yeah,
All
I
right.
haven't studied these in a while. So I'm gonna be real with you. Like I've been doing more cardio and neuro because those are I like musculoskeletal, but cardio and neuro are probably my weaker areas. So like if I compare it to musculoskeletal. So all right. All right, so you can start off with the first one, and I'm gonna try to just remember because it's been a while since I've gone over these.
Sure. All right. So, what is the capsular pattern of the shoulder?
All right, so capsular pattern of the shoulder. Damn. Oh, let me see. It's lack of. I think it's the first one. You get the most lack of. I think it's external rotation, abduction, then internal rotation.
Yeah, that's it. Yep.
Let's see. Oh, I got it right.
Yep.
Okay. Boom. We off to a first
Hey.
start. All right. So if you didn't know that one, so right now we'll just kind of like basically go through and just talk it through. And then so once I answer it, then you just remember it for the next time or whatever, and we'll just loop it around. So I'll put that one for I didn't know or whatever, just because I'll swipe that one to the left because I'm doing it with you or whatever. And it was a little bit I kind of was slightly guessing ish kind of. It's somewhere in there. I'm just trying to bring it out. So yeah, so if you see in like the clinic when I saw at least patients and stuff like that, usually they would have a problem with external rotation, like shoulder cuff, rotator cuff repairs, labral tears. Even though the capsular pattern is really just dealing with the joint capsule, right? It's not really dealing with the actual like contractile muscles or whatever. So like, let's say someone has adhesive capsulitis, or which is just a frozen shoulder. The first thing that goes in that onset phase, and I know this just because I've been studying the shoulder from Final Frontier, external rotation is the first thing to go, you know. So that's kind of how I remember it. Usually with patients, for whatever reason, they get lack of external rotation, the abduction, then the internal rotation. So external rotation pretty much would just be reaching behind your head or going like this. Functionally, it would just be reaching behind your head. Abduction, of course, any overhead movement. And then internal rotation is like tucking in your pants. So those three are limited. So the most limitation, external rotation, then abduction, then internal rotation. All right. Okay. How about this? I'll go through it first. I'll try to remember, and then then I'll do it with you. So we'll kind of talk
Yeah.
like this. We'll just do 7 at a time. All right. So what is the
Okay.
capsular pattern of the elbow?
Um,
Um, well, you can guess. You can
you-
guess it.
yeah, I'm gonna guess. Is it flexion?
So greater loss of
More flexion, like you lose more flexion versus extension.
yes.
Flexion,
I'm pretty sure
extension.
that's
Yeah.
right.
Okay.
Yes.
I'm gonna swipe left on that
Greater
one because
loss of
I
elbow flexion. So basically, capsular pattern again is just dealing with the joint capsule. So one of the things I was with Final Frontier, and this is actually interesting because in the acute care hospital, we saw a guy, and I think he had some of this. He was in the psychiatric unit, and he slept on his arm the wrong way or whatever, and he started having problems with overhead movements, and then reaching out now or reaching like behind his head like that. His external rotation was really limited. And two of the things that just from studying I've learned is that people with thyroid disease, and I don't know the rationale behind it, or diabetes, which pretty much most of the patients in the acute care setting have diabetes, they actually give you an increased risk for these capsular patterns of the shoulder. I don't know why, but that was just like a random fact that I realized. So I asked him if he had diabetes, and he did. And oddly enough, because his just happened spontaneously, I was like, well, did you sleep on it wrong? He was like, it kind of just happened randomly. So he said he'll talk to his doctor, but yeah, capsular pattern, external rotation gets that limited, but in elbow, so we'll just go through kind of back. So for shoulder, external rotation, abduction, internal rotation, and then for elbow, lack of more flexion than extension. So we're focusing on the capsule that's tightening up versus the muscle itself. All right. All right.
All right. So the next one, what is the capsular? What is the capsular pattern of the hip?
Yeah, this one. All right, I'm gonna take a stab at this because I really don't exactly remember. I think this one, the way I was remembering it was kind of the opposite of the shoulder, if I'm not mistaken. So I'm gonna say greater loss of internal rotation, then abduction. No. We're with the hip. The hip is actually equal. There was like three that were equal. I think it's flexion, abduction, and equal loss of flexion, abduction, and internal rotation. Those are all greater than external. It's something like that. I'm gonna be real with you. I don't really know.
The only thing was yeah, it's greater than extension.
Oh, so equal loss of flexion. Okay, so I was kind of right. Equal loss of, yeah, internal rotation, flexion, abduction. Those are all greater than extension, not external rotation. Okay, extension and not external rotation. All right, so I knew it was like an equal something, and these are just weird. So with the hip, if you have capsular pattern, you're gonna see a greater loss of internal rotation, then flexion, and then abduction. Those are all the greatest losses. I guess these are all equal, whatever that means, because these are relative range of motions. But that's all greater than external rotation. I mean, extension. Dang, I keep on saying external rotation. Extension's out of this. Okay. All right, so let's just circle back around to the first one. I'll let you do it this time. Let's kind of just do it back and forth like that. Let's go from the first one that we did, shoulder, elbow, and then we'll go hip now. All right, so I'll let you say it this time.
So with shoulder is the capsular pattern for shoulder, internal rotation, um, abduction, and then uh, external
Tucking in your
rotation.
pants. So I just think
Yeah,
head
abduction. Yeah,
and then pants.
external rotation, abduction, internal rotation, internal rotation. Yeah, and then what was the other? Elbow flexion is greater than extension. And then the third one is capsule pattern for the hip. So internal rotation, flexion, and abduction are equal in their limitations, and then they're all greater than extension. Or you don't get any extension. Is that what your equation was showing?
Say it one more time.
For the capsular pattern of the hip, so it's you internal
Uh huh.
rotation, flexion, abduction
Uh-huh.
are all greater than extension.
So internal rotation. There's internal rotation. There's abduction. No, there's internal rotation, flexion, and abduction. All are more limited than
Or limited.
extension. Yeah, all are more limited than extension. And then for the elbow, of course, we know it's greater flexion than extension. Okay. All right, cool. Let's go to the next one.
What is the what is the capsular pattern of the knee?
I'm pretty sure the knee it's very similar to the elbow, so I think it's greater loss of a greater loss rather of knee flexion than knee extension, if I'm not mistaken. Yeah, okay. So we can start making a little connection here. If we think about it, the knee and the elbow, those are pretty much one plane of motion, right? I mean, yeah, if you think about the screw home mechanism, there technically is a little bit of what external rotation at that end range of knee extension that locks the patella in. So, in a sense, that would be what? What's this plane?
Transverse,
Up and down. I'm tripping
sag,
right now. I think I'm on live.
sag,
So we have the sagittal plane that it's moving up, and then the coronal plane, right?
coronal transverse, they interchangeable.
Up and down, right? Coronal. Transverse. We'll just call it
Transverse is
transverse. I think coronal is the same thing as transverse, though, if I'm not mistaken. Hold on, I need to look that up. This is bad.
coronal and transverse are
Coronal
interchangeable.
plane.
Yeah, frontal plane and
Oh yeah. Okay.
sagittal.
So I was right. No, sorry. Coronal plane is front and back. Never mind. So coronal and
Oh,
frontal
okay.
together. Transverse and
Jeez.
horizontal go together. Whew. That's rough right there.
Transverse and what go together? Transverse and
Say it again.
which ones go to transverse and which one? Transverse and what go together?
Yeah. So in the transverse plane, technically it would be the knee would be moving in a little bit of external rotation just because of the screw home mechanism, but we'll just keep it simple now, just for the sake of this, because it is only talking about two planes, or one plane rather. So, elbow, knee, same. Greater loss of flexion than extension. We'll just call that the same. Oh, and I definitely forgot to start the timer. That's crazy. All right, starting timer now. That's wild. Anyway, we did a couple minutes, so that's cool. Okay. All right, so let's just recap. All right, so I'll run it through this time. So for the shoulder, we're gonna have greater loss of external rotation, abduction, internal rotation. For the I'll do the shoulder and the hip first because they're the hardest. Hip is gonna be um, internal rotation, flexion, and abduction all equal loss, but they're all greater than extension. And then the knee and the elbow, we can just pair those together because greater loss of flexion with the elbow, and then the knee is the same thing. Greater loss of planar knee flexion and elbow flexion than extension. So we'll just go with that. All right, next one. Ooh, what is the capsular pattern of the ankle? I think the ankle, yeah. We can throw the ankle in there too.
Hmm. Maybe I must take a stab. Dorsiflexion is
Dorsiflexion's
more.
what greater loss or less loss?
I was saying greater.
Okay, greater
But
loss of dorsiflexion than plantar flexion.
I think
I think that might be correct, but I don't know. No,
nah. It's
opposite. Greater loss of planar flexion than dorsiflexion. Yeah.
okay.
And this is all from so with Final Frontier, this was pretty much the readings in Final Frontier that I just got this from. It's one of the sections in the book, and I was initially not going to read it, but I'm like, nah, I probably need to because although it's basic, um, yeah, it's definitely stuff we need to know. So, all right. So greater loss of planar flexion and dorsiflexion. All right. So I'll let you run. So you go ahead and run through the top from the shoulder.
All right. So for the shoulder, external rotation, abduction, and internal rotation are limited. For the elbow, flexion is greater than extension. Well, flexion is you have limited flexion in
Yeah.
comparison to the extension. For the hip, internal rotation, internal rotation, flexion, and abduction are all equally limited and compared, and they're all greater limitation. There's greater limitation of flexion, internal rotation, flexion, and abduction compared to extension. And for the ankle, plantar flexion is more limited than dorsiflexion.
Yep. Yep. So the thing about it's funny about the ankle, it's both flexion motions, but if you think about it, I don't know, it's technically both flexion motions, but maybe this will help you, maybe not, but it's just a connection I made just talking it out. If you think about planar flexion's almost similar to extension. You know, if you think about it, there's still planar flexion, but it's straightening out the joint versus dorsiflexion. Well, like elbow flexion, you're flexing it. So maybe a way to remember it, it could help. If not, just discard it. Is just think about it being the opposite of the knee and the elbow. So with the elbow flexion, knee flexion most limited, then extension is less limited if you have a capsular pattern. And then the ankle's just opposite. If you think about ankle plantar flexion as extension because it's straightening out, then that might be something to help. So it's just the opposite. Okay, so I'll run through them this time again. All right, shoulder, greatest loss of external rotation. Then second loss is abduction. Then internal rotation for the shoulder. The knee and the elbow are going to be greater loss of flexion. The ankle is going to be the opposite. So greater loss of planar flexion than extension, dorsiflexion. And then the hip is going to be internal rotation, flexion, and abduction, all equal loss compared to extension. All right. So that's 5. Okay. Next question.
Capsular, I got you. Capsular patterns are usually associated with what condition?
So capsular patterns, according to the readings, are usually associated with osteoarthritis. I do remember that. Okay.
And
All right. Now, for the basics, you have concave moving on convex, right? You have concave, right? Moving on convex. What direction orthokinematically would that joint be moving? So let's just make a practical example. For your metacarpals, I believe your distal radius, let me just look this up real quick. Just let me look at my little atlas. No, that's not a good example. Oh yeah, okay, so the elbow, right? The elbow's a perfect example. That's the easiest one, right? So you have your olecranon fossa, right? Is moving on your trochlea, capitulum, one of them. This moving on your humerus. Your humerus is the convex side, and then the ulna is the concave side. So what direction orthokinematically when you have concave moving on convex? So if I do elbow flexion, what is the direction of the roll / glide slide? Are it the same direction or are they opposite directions?
You're in the same direction.
Yep. So concave moving on convex is always going to be same direction. Concave moving on convex, right? So when I do this with my elbow, right, the orthokinematically, the and this is really kind of dealing with more like when you get into like mobilizations and stuff, they're going to be moving in the same direction as they are sliding on the humerus. All right, cool. Okay, so that was a fire round. So now let's just go through it one time straight. All right. So we've already gone through all of these. Okay, so we got 7. So now we're just gonna do rapid fire round. And for these ones, you're gonna click your own statistics on it. Okay. So if you don't remember it, I'll say it one time, you'll say it one time just to make sure both of us know it, but we'll still like switch off with questions. All right. So now you'll just have to reset the cards. So we'll still stay on those 7. We'll do one more round of that, and we'll go through our next 7. Okay. So, Allende, what is the capsular pattern of the shoulder?
External rotation, abduction, and internal rotation.
Okay. So, all right. So when you're saying it, it's just just to make sure it's not taken for granted, external rotation is the greatest loss, right? So when you're saying this, just distances for whoever's watching, external rotation is going to be the greatest loss that you're going to get if you have a capsular pattern. So let's just say the capsule tightens up like in frozen shoulder. External rotation is going to be the greatest. So that you're going to have the most limit of rotation. Like if I was going to do the range of motion for external rotation, which to be honest is not very much. I don't really remember the exact number, but external rotation is going to be the most limited. Then abduction, your abduction should go theoretically to 180. And then your internal rotation is going to be the least limited. Okay, good. All right, your turn, or my turn.
So what we got? So what is the capsular pattern for the elbow?
Greater loss of elbow flexion than extension. What is the capsular pattern of the hip?
You have there's an equal loss of internal rotation, flexion, and
Yep.
abduction compared to
Yes,
extension.
sir. Good.
What is capsular pattern of the ankle?
Capsular pattern of the ankle is greater loss of plane. Say it again.
Now go ahead. I skipped one,
Yeah,
but
you
go
skipped it.
ahead.
It's
Go ahead.
cool. I'll run it back for you. So, greater loss of planar flexion than dorsiflexion. It's fine. All right. So now I'll ask you the one we'll skip. What is the capsular pattern of the knee?
Greater loss of flexion over
Good.
extension.
Okay. All right. And the last two, I think you asked me, so I won't answer this again. What condition are capsular patterns usually associated with?
Osteoarthritis.
Good. All right. So sweet. So we had those first seven. We got through seven. So let's unstar those seven and then star the next seven. That's usually how I do it. If I'm not using Anki, what I'll do is I'll pick seven and I just go in blocks of seven and I'll just rep. And then of course you might forget some of it, but then it's this active recall. They call it space repetition. That's really what Anki is good for. That's what kind of deepens the impression. So different people different. For me, I struggle with remembering things like numbers and stuff. So it has a number. I'm going to have to study it more. All right, so we're going to go through now Maitland's mobilizations. We're going to start from there. So that one, and we're going to go all the way. And these are also from the readings from Final Frontier, which is why I really definitely need to start. I enjoy the lectures more, but I need to start going back to the readings because I'm just looking at how much information. All these cards were just made from the readings. And we get to go to Frozen Shoulder. There we go. So it should be from Maitland's mobilization to the 4 stages of idiopathic frozen shoulder.
Oh, okay. I just realized how you see. I was starring mine differently.
Yeah, it's just a order. So what I do is I pretty much I like it to create almost like a story. So
Yeah.
first we go into
Okay.
capsular patterns. Now we're gonna go into mobilizations because that was just the second thing in the book. I'm really just following Final Frontier's, sequence. And they have it all very nicely kind of squabbled out, if you want to say, or outlined. Okay, so I'll start with the first one once you finish. So it should be from Maitland's mobilizations all the way starred. The last one you should have would be what are the 4 stages of idiopathic frozen shoulder?
Just the first one.
No, that's the last one. The first one should be describe the grading for Maitland's mobilization. Because the last one we finished on was concave moving on convex. So if you go back to the study all,
Okay. Yeah.
just scroll down because they're all in order right here. So just scroll down from the study all and then describe the grading for Maitland's mobilization. That one you should, yeah. All right, so you got all those 7 starred?
Mm-hmm.
Okay, cool. All right, so now you'll click into that study section and then we'll go into flashcards. Okay. All right, I'll start with the first one. Hold on.
Give me a second. Hold on. I ended up going into the app. Oh, never mind. Let's see.
Yeah.
Start. Okay.
Okay. You ready?
Give me one. Just change the. All right. Yeah, let's go.
All
Ready.
right. Cool. Okay, so you can read the first one.
Describe the grading for its mobilization.
Yeah. So you have this is pretty much just dealing with mobilizations from one mobilization from level 1 to level 4. So the first two, I like how they broke it down, are used for pretty much pain reduction, grade 1 and grade 2. And then grade 3 and grade 4, that's used for more so if you're trying to get more mobility or range of motion. So they called it something sandwich. I forgot one of my professors, but basically on the outer, you have the fast amplitude or high amplitude, if you want to say, real quick, kind of mobilization. And then it's going to be number 1 is going to be you start with the joint. I think it's, like I said, I haven't reviewed these cards in a while, so I'm going to really need to do that. But with grade 1, you are starting from the there's no the joint is at slack, and what I mean by that is there's no tissue tension. So let's say if I had my finger right here, if I start to pull it, it's gonna start from there. Like they do walls, and that's the picture is kind of nice because it shows the walls. So I'm starting with the wall pretty much closed, then I do a little fast grade. Then when I go to the second grade, it's still so this one is, I think they're fast at the ends, number 1 and number 4, and then the middle are slow amplitude. But the second one, I believe, is going to be second grade of mobilization is going to be, there's a little bit of taut, so some of that slack is taken up. So let's say I start to pull on my finger a little bit, some of the slack is starting to be taken up, and then I were to pull. So the wall is, if you think about it, like the door is kind of cracked open a little bit. So first one, the door is completely closed. The muscle is, or the joint rather, is kind of on slack and all the connective tissue. And if I were to kind of go a little bit further, that one would be, the muscle will be on slack. So then the muscle, some of that slack is taken up. The third one, some of that slack is even taken up more. So the muscle is starting to be, or the joint capsule rather, is starting to become more taut. So it's a little tighter, but it's still slow amplitude. But I have more tension. And then the fourth one is, I think, fast amplitude, but you're pretty much at that gate, And then the fifth one, by that time, you're just doing a high thrust or a high velocity manipulation at that point. Is that right?
Mm-hmm.
Something like that.
Yeah, that's when you're getting you're aiming to get like the cracks and the pops. Those are the famous stuff you hear. A lot of chiropractors do a lot of high
Yeah,
amplitude.
yeah. We don't do as
They,
much high velocity. So let's see. Yeah, so small amplitude for the, and I like that picture that they drew in the note cards. If anybody's following along, you can just look at the, all of this is from Final Frontier. That's what I'm using to study. So from some of the readings, I've went and made flashcards and stuff. I'm a person.
is your Quizlet
Say it again.
is a Quizlet in the YouTube? Like if
I
you click
probably
on the
should. Yeah, that's a good idea. I'll throw it in the YouTube link. It's not
I
right
mean the
now.
Quizlet link. The Quizlet, like your Quizlets,
Say it again.
you're gonna put your quizzes in the description.
Yeah, I'll probably do that. Yeah, I can do that.
Huh?
Yeah, I can do that. Yeah. So, okay. So like we said, so the grade 1 and 2 are for pain reduction, and grade 3 and 4 are mobilization through end range stretch. So the grades 1 and grades 2, they're actually, so I mixed them up. So I said they're large amplitude. Those ones are actually small amplitude. So 1 and 4. And then 2 and 3, those ones are large amplitude, right? And then the grade 5 is a high velocity thrust. So I got it mixed up. So small amplitude on the outsides. So basically by the time, which makes sense because by the time you get to grade 4, you've pretty much taken up a lot of that slack and you're really just kind of doing a little bit of a thrust, if you want. It's not a thrust, but a small amplitude mobilization. But for grades 2 and 3, those are large amplitudes. So grades 1 and 2, 1 and 4, those are small amplitudes. Grades 2 and 3, large amplitude. Grade 1 and 2 for pain reduction. Grade 3 and 4 for mobilization through end range. And then grade 5 is just a high velocity thrust. Woo! Okay. Those are really important. So, yeah, we need to get that. Okay.
Did you make this drawing?
Good ahead.
Did you make this
No,
drawing?
that drawing's from Final Frontier. So, hold on. No. That's from the internet. It's not from Final Frontier. Final Frontier has like a copyright thing that they're doing, but no, it's not from Final Frontier. I found that on the internet because I was having a problem. Like in school, you always heard about, okay, well, is that a grade 1, grade 2, grade 3, you know? So this concept is a concept that I really had to hammer down. So that boat picture where the boat's like leaving the shore or whatever, as that rope is kind of leaving, it's kind of, you see, it's like whatever. That's all from that's all from the internet. So if you see the slack, by the time the boat is reaching all the way, if you could see that little rope right there, the slack is pretty much taken up. Yeah. So by the time you get to grade level 4, there's not very much slack. Okay. All right. So let's look at the next one. Let's try to bust through these in the next 10 minutes, or at least 3 of them, because these are a little bit more conceptual. All right, so Allende, a posterior glide of the glenohumeral joint would be indicated to increase what motions of the shoulder? So a posterior glide. So basically, if you think about a posterior glide versus an anterior glide, the posterior glide, the glenohumeral, the head of the humerus rather, is literally moving backward, right? Or rolling or gliding backwards. And then anterior, it's gliding forward. So
with flexion, that was.
So this one's
when you're
tricky.
flexing.
This one's tricky. Okay, so what were you saying? You said what?
Yeah, you're flexing your shoulder. You're going to GH is going posteriorly.
Yes.
I also want to say when you're externally, internal rotation. Yeah, internal rotation. You also have horizontal, and
Okay, so don't go in horizontal adduction or abduction. We're gonna keep that one out. So these ones, flexion,
okay.
extension, internal rotation, external rotation. So I'm pretty sure you're right. So you have the flexion when I'm coming. Okay, so internal rotation. So if I'm gonna internally rotate my shoulder, right? If I'm internally rotating, if you even feel the head of your humerus, it starts to roll forward. So if I'm in anatomical position, right, and I'm internally rotating my shoulder, I'm coming here, I'm starting to do a anterior roll. But if I were to keep on rolling anteriorly, then the head of the humerus would just roll off, or outside of the glenoid cavity, it would just roll off, right? So if I do an internal rotation here, I'm starting to, if I'm coming here, if you think of, if I were to put like a point here, like I think about it visually, I am starting to roll, my shoulder's starting to roll forward, but as it rolls forward, it has to slide backward, right? Let me just make sure I'm saying the right thing. Yeah, internal rotation, good. So internal rotation and flexion are the two. You are correct about that. As I internally rotate, I'm rolling forward here, and then I have to slide posteriorly. Because if I were to keep on rolling forward like this and there was no posterior glide, the head of the humerus, I would just roll out of socket, right? Flexion is similar. I'm coming up here as I'm coming, if you even think about it, and it's really easier if you have a skeleton. As I'm flexing right here, going through this range of motion for flexion, after a while, or shoulder flexion, right? I'm coming anteriorly. If you think about it from like anatomical position, I'm coming anterior, rolling, but after a while, I'm gonna have to, same thing. Or if you even think about extension, hold on, let's see, flexion here, flex, shoulder flexion. Huh? No, hold on. Yeah, let's think about this. Those two are right. I'm just trying to remember the explanation that they gave. If I flex my shoulder, I.
Where's a ball and socket joint? So like where direction is the ball going in relation to where the socket is?
So I understand the one for internal rotation. Now that and I'm, this is good we're talking this out, because you need to know how to explain stuff if you understand it. But I get it for internal rotation because that ball would roll out of socket. I remember them saying that on the video, and it just conceptually, like visually, it makes sense. It would roll out of socket
So
if
let's go back to yeah. The thing about what's moving on what. So this also you can take the card. So we have the GH joint here. You got the ball, which is the
convex.
yes. So you have the ball, which is the humerus. And so basically that ball it's in that socket. When you're moving going into flexion, that ball is what's actually going posteriorly to allow you to take your hand back. You can even look at it, wherever the direction of your hand is going, because the ball is moving on the socket. So think about the direction of where your arm is actually going. Where you going? You're going posteriorly.
So, but hold on. So, but if hold on. So, but there, that's if you think about the convex versus concave rule, that's convex moving on concave. So it would have to be opposite directions. So if my ball is moving, if it's moving anteriorly, then I would have to slide posteriorly. Let me see. Anterior roll. I'm gonna come back to that one. I mean, I know it's the
Yeah.
opposite, because that one, it has to be opposite, because the glenoid cavity is concave. Yeah, concave. And then the glenoid cavity is concave, and then the head of the humerus is convex, right? So if I'm coming here, and I always get confused with the ball and socket joints, they're just weird. Like abduction is easy, you know what I'm saying? Because I'm literally going out, I'm doing a superior roll, inferior glide, right? But when you get into this plane, it kind of gets a little bit more tricky. I do understand the internal rotation though, because my ball is rolling forward, so it has to slide backwards because it's opposite. Convex moving on concave is opposite. But I get always get confused with the sagittal plane, because in my opinion, like if I'm right here, it almost looks like I'm rolling posteriorly. Hold on, let me check that out. Let me make sure I didn't make a mistake on this. Of arthrokinematics of shoulder flexion.
I'm if it's for flexion, it's definitely posterior glide. That I am positive about.
Yeah, okay. Oh, so here's what they're doing. Okay. That's what it is. So flexion and extension, they're a little bit different, because it's spin. Because it's a ball and socket, it's like a spin, right? So when I'm coming, for example, an abduction, you have your clavicle, right? And your acromion, or your acromion and your coracoid, or whatever, your AC joint, you know what I'm saying? That basically acts as the shelf. So if I'm abducting, there's a point in time where if there's not a post, like if I'm abducting here, if there's no inferior glide, I'm going to basically get, which is pretty much seen in like shoulder impingement, right? If there's no inferior glide, it's going to hit the roof of my
Yeah.
AC joint, right? But when we're dealing with flexion and extension, they're really only taking into account, because it's just spinning. It's a posterior spin, literally. There's nothing to bump into. I'm just spinning. So as I'm coming here, the ball is rolling backwards. So they're considering it posterior spin. The other ones, like internal rotation, abduction, that's superior roll, inferior glide. They're paired with two because there's another component that's involved, which is your AC joint. I have to do that inferior slide, if you want to say, or glide, in order to get that full,
All the way range of
yeah,
motion.
in order to get that full range. But when you're dealing with flexion and extension, it's literally just spinning. If you think about it, there's nothing blocking it really. It's just either spinning posteriorly or spinning anteriorly. So extension, it spins anteriorly. If you think about it, it's just spinning, it's coming forward. And flexion, it's just spinning posteriorly. So yeah, that's from Physiopedia, and I do remember them saying that as well. Yeah, with the ball and socket, those are weird. Now, when you're dealing with like your elbow, it's a little bit more simple because they're not ball and socket joints. But all right, okay, we spent a good amount of time on that one. All right, let's go to the next one. We'll come back to that one.
Yeah, now these referral pain patterns,
Yeah,
I definitely
uh,
need to go through those.
yeah. So the referred paid pattern of the heart. That one, I believe it's the left shoulder and axilla. Something like that.
So yeah, switch it a little bit.
Um,
So instead of the left
left
shoulder,
axilla
yeah,
and shoulder, tips of shoulder.
and yeah, I guess so. You
And
could
let's
call.
see
I
what
mean,
it
because
is. Perceived pain
that's
in
part of the
and
pain.
pectoral region. Oh no, I'm thinking about the gallbladder. I'm thinking about the gallbladder. Okay. All right. That's I messed up there. Okay, so you're right. So yeah, bro, let's just keep on. I mean, I know it says break screen, but we'll just reset the counter. Let's hit another because we were doing it a little bit more. Let's hit another. I didn't start the timer. Let's hit another because I'll have to go to the train in a second. But let's hit another 15 minutes. Yeah, let's hit another 15 minutes. We'll just keep going with it. Okay. Well, I would like to get through at least this section. I think this is good. All right. Let me just change it on the thing real quick, and then we'll do another 15 minutes, and then we're still working this out for the people who are watching. So this is our first time, but both of us want to pass this NPT the first time, and honestly, that's what we're here to do. All right, so we'll go 15 minutes again. Countdown timer is now back on to 15, and I'll start it on my phone. Okay, let's just keep going down that path. Okay, so perceive pain in the left axilla and pectoral region, which makes sense because it's your heart. Some of these, we try to memorize things or whatever, at least for me, and then like if you just think about it, it's like, okay, pectoral region, yeah, heart makes sense, right? Okay, so we'll re up that one. All right, so what is a referred? I kind of said it just last one, but what is the referred pain pattern of a gallbladder or the gallbladder?
So you said previously it was the shoulder
Yeah, it's like the tip
region.
of the shoulder blades and then something else. I forget.
So you still include the axilla. So is the axilla still a part of it? You just switched it. You said,
I don't know. I don't really know on this one. Let's see.
let's look it up.
Oh, okay. So tip of the shoulder and scapular region.
Okay.
Yeah. No. Yeah, that one. I messed up that one. So tip of the shoulder and scapular region. And this is all from the readings in Final Frontier. I'm just getting this from the book. So yeah. Okay. That's pretty simple. Okay. All right. Whose turn is it? Oh,
So we
my
already
turn.
said gallbladder. Okay. So
Go ahead.
We already skip the gallbladder since we are
We'll run
just
that one back because I didn't know that one for sure, for certain. So we'll run that one back, the gallbladder one.
okay.
I'll run it back. I put it run it back on my screen. So all right. So I think I got the next question. What is it?
What is another name for idiopathic frozen shoulder, etiology, and
Okay.
age? You got like three
Yeah,
questions
it's a
on here.
lot. I'm piling this one. Oh yeah. Okay. So
What patients commonly seen in the acute care setting are at increased risk of developing this disorder?
yeah. So this is what kind of we talked about earlier. So another name for idiopathic frozen shoulder is adhesive capsulitis. There's unknown etiology because it pretty much comes, it kind of springs up. I know the age group. I do remember this one, and I've been able to make the connection because I've actually seen this in the clinic, like during this acute care rotation. Because that guy was in his 50s, so the age range for this, and I've also remember seeing another 40-year-old woman. She came into the clinic at Andrews, or she was like 42 or something. She was in church and she put her arm around her mom. And by the time she was done, she had like literally couldn't even lift her arm above her head. It just happened randomly. They don't really know the reason why it happens. 40 to 65, that's the sweet spot for it. And patients that are commonly seen in the acute care setting, you're going to see a lot of patients with diabetes. So that is one of the risk factors. Maybe not as many with thyroid disease, but I believe that is another one of the risk factors for this disease. Or not disease, condition, if you want to call it that. So, adhesive capsulitis, or periarthritis. It is so I just flipped the card. Um, it's unknown etiology, like I said, 40 to 65. And it's pretty much just development of dense adhesions, capsular thickening, and capsular restrictions. And the patients that are most at risk for this are patients with diabetes or patients with thyroid disease. So if you guys do chart review, I know pretty much everybody's, well, maybe, I don't know where everybody's at in their PT journey, but if you go into an acute care setting, you do chart review, pretty much everybody's going to have, like, bro, over 50% of my patients, if you look at them, or at least, at least 50%, because most of the people we're seeing are a little older as well in the acute care setting. Most of them have diabetes. Thyroid disease, I've seen with this rotation in the 3 months I've been there. I think I've seen one person with hypothyroidism that I remember looking at via the chart review, but diabetes for sure, either type 1 or type 2. A lot of the times type 2, though, because these people are becoming their insulin sensitivity is not as high, basically based on their poor lifestyle. Type 1 is just, you're born with that. Your body doesn't produce, your pancreas doesn't produce insulin. But type 2, that's where your body kind of becomes insensitive based on the amount of carbohydrates or whatever that you're eating. So, all right. Next question. Allende, with chronic GH joint arthritis, and honestly, bro, this one is just, just you could just take a guess.
Oh,
With chronic GH joint arthritis, what motions are most limited? What motions are patients most limited in?
um, so based on our understanding of the orthokinematics, like we know what the motions of the GH joint can and doesn't do. We kind of briefly talking about it earlier when we was talking about the rows and glides. So I go with something dealing with overhead, abduction, basically the entire capsular pattern, flexion, abduction, internal rotation.
Yeah, pretty much. I actually just noticed that. So it's a little bit of a tweak. It's almost chronic GH arthritis because remember, just to make the connection, capsular patterns are a lot of the times hooked with osteoarthritis. This didn't
Mhm.
necessarily say osteoarthritis. It's just, I mean, osteoarthritis, joint arthritis. I guess those are interchangeable, but chronic GH joint arthritis, you're gonna have problems with overhead reaching. And in the clinic, if you see older patients, who might have had shoulder surgery or just overuse, a lot of the times when you're doing a manual muscle test or even just because what we'll do is we come in, tell the patients to hold their arms like this. Can they punch into the ear, right? Then hold here. Don't let me move you. Push, pull, wrist strength. We say, well, at least this is how my CI told me to do it. You put the two fingers here, grab as hard as you can. Can you feel me touching your hands? Whatever, bloom. That's just the general screening. Most of the times when you tell patients to do this, they can do it. You push, pull, they're good. Now you tell them to punch straight up into the ear. This is pretty much where they got. Like I've seen patients. Now some of them do have that increased, which also makes it worse, the forward head posture with that increased kyphosis. So their upper thoracic spine is already kind of curved like this. So they're already in a bad position. Because if you think about it, they're like this. They got that hump. And then you're telling them now to punch up in the air. They're like this. Pretty much. Like some of them have had rotator cuff injuries as well. But you tell them to punch up in the air. Most of them, even the ones that don't necessarily have like acute problems, most of them, they're like this. And that's pretty much the extent of it. So if you think about that, if they have any arthritis in their shoulder, which by the time, arthritis is just, it's just really joint inflammation. By the time you hit 65, I mean, I know I have some arthritis just from jujitsu and stuff like that. So it's like, by the time you get to a certain age, gravity and life and wear and tear just does a number on your body. So
Yeah.
overhead reaching, they definitely have problems with that. They're gonna have a problem with reaching outward. So if you think about it, it's almost like abduction, right? When you have a patient, like we would have patients in the clinic, maybe they can't abduct their arm like that actively, but guess what? We have them put their arm on a table. We give them some type of cloth, not cloth, what's the word? You give them like a towel, for example, and you just tell them to reach as far as you can. And as they reach, if you think about it, they're really going into shoulder flexion. So if I'm here, there's no way for me to reach, even if my hand is supported. As I'm reaching, my arm is going into flexion, even though it's supported on the table. So problems with outward reaching, problems with reaching overhead, and then, I mean, internal rotation. You tell some of those patients, you do that thumb test where you tell them to take their thumb and put it up as high as they can. I know I was having a lot of problems initially with this shoulder because I had partial tear in my subscapularis. And if you think about it, subscap is the only muscle that's really doing the internal rotation outside of their subscap and then one of the teres, I think. And then the lat. The lat also,
Okay,
I think,
Theory's
does.
minor, right?
I don't want to say. I don't know. Let's see. Let's
I
check
mean,
it. Let's check it. I'm gonna go to my atlas right now, real quick. Teres major.
okay.
Teres major is doing internal rotation. Teres minor is doing external rotation. And the way I
Rotation.
remember that is I probably need a better acronym, but when I was thinking about rotator cuff muscles, it externally rotates. IT, infraspinatus, teres. So I got at least teres. It externally rotates. So internal infraspinatus and teres minor. So I would probably put it.
No, you can still use the it. It just be Terry Major though.
No,
If
no, no.
it's
Teres
infinite.
minor. Teres
Yeah,
minor. So maybe
you
if I
said
think about it like this. It
yeah.
starts with I. MINOR.
I thought you said it internally rotates.
It externally rotates.
Oh, okay.
So that's the way I remember which of the teres does external rotation versus internal rotation. Your main internal rotator is your subscapularis. However, your teres major, if you look at the attachment, I'm just looking at the attachment point. It's going from that, it's in Essential Anatomy Atlas. It's going from the tip of the scapula and it's going right into the inner part of your humerus, right? So it externally rotates. That's for the infraspinatus and the teres minor. And a way to remember that, I just IT, right? Like infraspinatus, teres minor, but this is how my mind works. Maybe this chuck this if this doesn't work for you. But minor major is major. So if you think about it, you could just use the I from it, infraspinatus, teres minor. It externally rotates. Infraspinatus, teres minor, both external rotators. A little bit of supraspinatus, but realistically, supraspinatus is really more for the abduction, right? And then subscapularis is the only one of the rotator cuff muscles that does internal rotation. So if you pair that with the teres major, if you just look at the teres major attachment, it's actually doing internal rotation. So, inability to reach overhead, outward, behind the back. I know we spend a lot of time on that, but I think it was kind of important. All right. So last one, we'll go to the hold on, did you just ask me that question? Oh. Hold on. Yeah, I just asked you that question. Hold on. Did I just ask you that question? Yeah, I did, because you answered it. All right. So you get the last one. The last one's for me, and then we'll wrap it up.
All right, so the final one is. Let's get to.
It should
All
be the
right.
stages, I
What
think.
are 4 stages of idiopathic frozen shoulder?
Idiopathic frozen shoulder. So in this one, I've I don't know. I've seen a lot of shoulder patients. So the shoulder stuff does stick with me for whatever reason. But you have 4 phases of idiopathic frozen shoulder, also known as adhesive capsulitis. You have the early onset phase where that external rotation starts to be limited, right? Then you have the freezing phase. Pretty much the shoulder becomes more painful, the capsule starts to tighten, and you have pain with all ranges of motion, if I'm remembering correctly. So overhead, back, behind, whatever. And by that time, usually the patient's coming into your office, at that freezing phase. Because if external rotation is just limited, people can kind of, outside of reaching behind your head, and unless you're a pitcher or something like that, you don't need a whole bunch of external rotations. It's really the internal rotation. If you're tucking in your pants, girls putting on their bra, zipping up their dress, internal rotation is going to affect you more if you have a lack of it. External rotation, not as much. Even putting on your seatbelt. That's more cross-body adduction, but like just behind the back stuff, there's just more stuff like functionally I've thought about it. So freezing phase, you have just pain with all motions. Then you have the scapulothoracic phase where I believe the scapula movement becomes more limited and you have basically like breakdown in the rotator cuff, the bicep tendon, and I believe it's the tricep or deltoid rotator cuff, and like tendon of the bicep. And then the last one, you have the thawing phase. So at this phase, some of the times people, when they have adhesive capsulitis, it just subsides on its own. And I remember reading that sometimes it could take up to 2 years. Sometimes they never get all the range of motion back, but it pretty much gets to the phase where it just almost like it just dissipates. Sometimes the patient will, like I said, get those range of motions back, and then sometimes they won't. That's what I remember. Was that pretty accurate?
Yeah, for the most part, it's pretty
Okay,
accurate.
let's see. So I'll just read the thing. So well, you can read it since this is you to me.
Stage one, gradual onset of pain. Pain increases with movement, limitations with external rotation.
Mm-hmm.
Stage two, you have the freezing stage, so it's intense pain. motion limited in all directions. Stage 3, excessive scapulothoracic movement, atrophy of deltoid, rotator cuff, biceps, and
And triceps.
triceps.
Okay, the triceps was in there.
Stage 4, thawing stage, minimal pain, motion gradually improves, but some patients never gain full range of motion.
Yeah. So that's pretty much it. That is so that's we got through the first 14. So what we'll do next time is we're still trying to really come up with a structure for this. I'm using Final Frontier, and our school's requiring us to use, for the people watching, our school's requiring us to use TrueLearn. Ayende, your school also requires you. You're at Alabama. They're using TrueLearn as well. Yeah. So we have a quiz on TrueLearn every week that we have to do while we're in clinical rotation, and then but I'm using Final Frontier as my main study source, and I'm doing TrueLearn just to get in the mood of answering questions. The only thing is that some of the questions on TrueLearn, I don't think they're as representative from some of the reviews and stuff that I've learned, but it's still questions, so it'll still hit concepts. We'll continue to go through this one. Allende will just kind of keep on studying this one. What we'll probably do is have like a study schedule. Like this week we're doing this. We're gonna go through this stuff, and then we'll go and kind of talk through it or whatever, just to let people know
Yeah.
what they're what they should expect once they come onto the live stream. Another reason we're doing this is also accountability. I know on Sundays a lot of times it's a slower day for me. I usually train and stuff like that, but with Sundays sometimes getting that extra motivation is a little bit harder. So what we'll do is we will do this every Sunday, 11 a.m. Eastern time, Eastern Standard Time. If you're on Central Time, 10, and if you're in California, well, you know. But yeah. So that's pretty much it. Allende, did you have anything else you wanted to add?
Uh, nah, like you said, we'll figure out get more structure to it, but nah, I don't have anything to add.
Yeah. All right. So for the people who are on, there's a couple of you guys, about 4 of you guys. Thanks for joining. We're pretty much done here for today, and we'll be back at it again next Sunday. We might do it a little bit more. I think this was pretty helpful, at least for me. Talking out stuff, it makes
Mm-hmm.
me realize what I don't actually know. So that's one of the things that's a really good benefit. So once we get our structure down, we might even jump it up to 2 times a week, but we want to just start with consistency. So we'll do Sundays. I'll chat with Allende. We're both aiming to take our board exam in July. I have to take a mock exam, the PET exam, in February 16th, and I have to qualify. I have to score a certain score to qualify to take it early. If I don't take it in July, it's October, and that puts me way too far out. So we're doing this for accountability, and we also want to make sure that we are studying, to be honest, talking through some concepts. And yeah. Alrighty. Next week, until the next time, you guys take care.